This is a 74-year-old woman, metastatic lung cancer that was undergoing chemo. And she had AVN from chemo. She had a fall, and she has this minimally to non-displaced acetabular fracture in combination with the AVN. So our plan here was to stabilize her columns and then convert her to total hip arthroplasty.
You're able to stabilize both columns really easily, particularly in transverse type fractures, and you'll see what we're able to perform with this technology.
The huge advantage of this implant, particularly in the anterior column, is that when you start converting to total hip arthroplasty and you start reaming, you're going to encounter implants. And this device can be reamed to some extent. And you're not going to have to break out trephines or metal cutting devices to work around metal implants. So it marries very well with your acetabular components.
And Billy, I think the other point there is not only does it can you ream it, but it increases the stability of the bone that might be thin in that area, and without that support underneath it, might just fly away as soon as you get attached to a reamer. And so I found it to be really beneficial in those cases too.
Definitely. Placed our devices, cured them, and at this point, I just hand the case over.
If you look at how this turns out, I, this patient stays supine and becomes a primary direct anterior hip with two screws. I mean, it's pretty life changing when you have a case like this that used to be this humongous headache, screws in every direction, terrible bone, and you're just able to get in there and put a cup like this, like it was just a simple primary hip. It's as somebody that sees a lot of these, that has struggled early in his career with a lot of these difficult cases, to see something like this is what we call practice changing.
Next case is a 40-year-old woman, Hep C, schizoaffective, had an intertroch fracture. This was treated by a partner with nailing, failed, had an intertroch of valgus IT osteotomy, failed. And then they call in our hip arthroplasty service to save the day.
Pretty protrudes to the get-go. You can tell here that they got into trouble, breached the medial wall, and what you can't expect to happen happened probably around 4 to 6 weeks. Can't walk, severe pain.
Yeah, so mostly anterior column insufficiency and quadrilateral surface insufficiency. I think that the IlluminOss is great because it does help stabilize the anterior column and is somewhat bone substituting. It gives you a foundation to build into. I wasn't quite sure if it was enough in isolation, so I planned for intrapelvic plating in addition to the IlluminOss. Because I was thinking I want belt and suspenders so that when you go and convert to your revision cup, that you're not going to have a problem.
I remove the proximal body of this modular, flying tapered modular stem. I remove the cup. So when I call Billy, I say, here, give me an anterior column of some kind or some support of the anterior column so I can get something into this patient.
Created a medial buttress with a plate, then IlluminOss to create that anterior column reconstruction, and then put in our pubic symphysis screws through the IlluminOss as well, increasing stability.
So here we have, 4 screws. We have maybe one into the pubis there that's obscured, and 3 very good screws, in a fairly primary situation here, which without an IlluminOss, in my opinion, looking at this back, this would have been an acute cup cage on a patient that is, if I'm not mistaken, in her 50s. So this gives her a very good potential for biologic ingrowth into this cup and a very durable implant. I think she might be maybe 2.5, 3 years out now. So,
Dave, what do you think the advantage of this over cup cage is? Because that's what we're saving.
sure. I mean, cup cage, you're cementing a liner into the cup cage. So we can argue all day about the durability of a cemented liner in versus this potential biologically ingrown cup with either dual mobility or this looks like a 36 head, maybe non-dual mobility. Durability of this for me is the potential for ingrowth of this cup and just a regular wear rate of a total hip arthroplasty.
This is an 83-year-old man, prostate cancer, radiation and hormone treatment, no surgery, started developing groin pain. His slides show that he's got a pathologic acetabulum fracture. That right there is an ideal situation for IlluminOss. Even I know this is traumaplasty, but by itself, you got a non-displaced acetabulum fracture, and with METs, I mean, that could have been done right there to stabilize his fracture, make his pain, and keep him mobile. Ultimately, he had this fracture. He underwent a total hip for pain, and the reamings and curettage were sent to pathology and were negative. He was touchdown weight bearing because it was into a pathologic fracture. It was not our case at this point. Keep going forward. So this is September. This is October. He's kept non-weight bearing. And then Christmas, December, he's continually needing more narcotics, more pain, still non-weight bearing, and clearly something is not right. And then this cup is just keeps on subsiding. The fracture is getting worse. At this point, he's going to get referred to us now. And there's a 3D after this that really shows the protrusio, both medially through the quadrilateral surface and superiorly through the anterior wall and column. Plan is to take everything out, stabilize the anterior column, recreate bone stock in the anterior column. Exact same principles that we just discussed. This time we did antegrade and we did posterior column fixation. I do believe there was some involvement in the posterior column as well. This is early on in our experience. I wanted to go and belt and suspenders and provide absolute stability. And we did intrapelvic plating again and then pass it back to David to convert to his revision cup.
That cup was solid. Again, practice changing the things that that's given us in terms of fixation and stability for the cup. He's out maybe 3 years out now. He was able to bear weight right away. We did allow him. This was a little bit further out, so we allowed him to bear weight right away.
No, I think this is at 6 weeks, I recall, and this is a guy that hadn't walked in a year.
Yeah,
That's incredible.
This is the last case that we had. This is a relatively younger woman. I think she's 60 or less. I think she was a dysplasia patient. That's why she has all the surgery. David did a revision surgery for her, and unfortunately, she was pushed down by her husband, fractured through her anterior column, stabilizing the anterior column with the IlluminOss. And then at this point, everything's stabilized. We flip her up onto her side and do the posterior approach. This is going through our acetabulum, and David starts to ream.
I started this reaming with a burr and then, created my shell. So after bone grafting, we still have a lot of bleeding bone, from 12 o'clock, as you can see, all the way down to the Homan and the operator foramen. Really happy with the fixation that we were able to obtain. Obviously, we went jumbo on her, trying to obtain as much contact as possible.
All right, so our first case, this is a very complex case. Let Dr. Thakral talk you through how this 96-year-old lady presented.
Well, this lady apparently had been on wheelchair for more than a year, 6 months, been getting worse, reasonably healthy, and her aim is just to get up, mobilize, and be in no pain. Big osteolysis and implant, which was done in early 90s, I believe, 30 years plus, and trochanter is broken. She was miserable. So nobody in town will tackle this problem until she arrives, and I had a discussion with Dr. Hull and what should we do to help her.
And yeah, so she's been to multiple surgeons in the community, and everyone has come to the conclusion, I'm sorry, you're 96, there's nothing we can do. So not only does she have significant bone loss from the anterior column, but she really has a lot of bone loss from the posterior column as well. So stability in this case is really challenging. Could we do a posterior approach? I don't know that we're going to get meaningful fixation from our screws along our posterior column. IlluminOss really, we felt like it was a game changer for us in this case. Loose acetabular component, we know we're going to have to revise that. She's got all this extensive bone loss. She's got the greater trochanter fracture. And then there's questions of her having actual instability within the cup itself. You can see the eccentric polywear. The questionable instability, turns out it's definitely there, right? You see her hip dislocated. And this is us starting with the posterior column. There's your deflated balloon. You can watch the balloon inflate, and it filled that space really nicely. And then again, with the retrograde anterior column wire, a second balloon was passed. And with those two balloons cured, Dr. Thakral was able to do a really nice cemented revision here. So these were immediate post-op films, and this is her just before her 3-month follow-up. And if I'm gonna fast forward a little bit through your patient information portion. But if you listen to her,
That's
the
awesome.
patient tells you right there she's having no pain. And this is a 96-year-old who hasn't walked for over 6 months, been in a wheelchair for a year, and truly just an incredible result. Our second case, this lady is 42, pain for the last month or so or two, and she's starting to progressively be unable to put weight. And so he makes her non-weight bearing with plans to complete that workup and then plan for arthroplasty. She shows up in our ER 2 days later looking like this. We had augments available and ready for her when we took her back for her arthroplasty. But with the LC2 IlluminOss and anterior column IlluminOss, we were actually able to put a very stable primary total hip in. And we actually let her weight bear immediately because we felt like it was really important for her to be able to walk. She also, if you notice, if you guys look back, there's a lesion in her proximal femur on the right. So 3 days after her arthroplasty, we did a prophylactic nail on the right side. And that's her at 8 weeks. I don't have video of her walking, but she was walking unassisted at 8 weeks and doing really well.
Yeah, that posterior superior tumor on the S-tympanum would be a big problem without some level of support like IlluminOss gave you here. I think IlluminOss provides a very, very good scaffold for cementation, with the irregularities that it brings into the shell portion. So this is phenomenal. It does have areas without tumor that do have potential for ingrowth. Let's say you had a full tumor S-tympanum where everything is just bad and you have IlluminOss in, like you showed in the previous case, phenomenal scaffold for cementation as well, both in infected cases and in cases with poor potential for ingrowth.